Okay. How do we go about doing this? So what the FDA tells us to do is you first have to find out M1. How do you find out M1? You need to first do a synthesis of the literature and find out, usually through a meta-analysis, of all applicable studies of the reference against placebo, not against something else, against placebo. And your meta-analysis in obtaining the effect of the reference versus placebo should do it not with fixed study effects, but random study effects, because you get a wider confidence interval. You should decide what studies to include, and then you get the 95% confidence interval for reference to placebo. Now you have M1. M1 is the lower bound of the 95% confidence interval, right? Because that's the smallest effect of that reference to placebo. Once you have M1, now you want to know is how much of the effect of the reference do you want to preserve in the new one? And so M2 has to be some percentage of M1. Standard thing is half of it. So 50% of the lower side of the confidence interval. Sometimes people say, well, we want to preserve a lot of it, so let's do 75%. But that's about as high as people will go. In many situations, even smaller M2 may be required based on what is clinically important. But usually I haven't seen it go beyond 75. How does this work? All right, let's look at an example. So suppose large values are good, and we have a continuous measure. So we're talking about additive case, looking at differences. So let's say we do our meta-analysis, and the reference versus placebo 95% confidence interval goes from 4.5 to 8.5. And so M1 is what? Is 4.5, but it's because it's a large values are good. We're looking at the lower bound, so we go to minus 4.5. This is the minimum of the reference effect, okay? So now we have M1. To set a margin that requires the test to preserve at least half, then we would have minus 2.25. So we would, if this is the lower bound of the confidence interval, we'll say, okay, we want to preserve this. This could be our margin. But if you wanted to preserve 70, it's easy to do it in the additive case, and this is what usually statisticians like. However, we work with, in biostatistics, we work with, or medical statistics, we work with physicians, and physicians like things in relative terms, right? So if we look at it in relative terms, we are talking now in multiplicative cases, and this is when we're talking like at hazard ratios or relative risk or odds ratios. And it's just a little bit more convoluted to think about it, but it's still easy, relatively easy to do. Now I'm making it complicated by taking large values are bad, okay? So we'd be focusing on the upper side of the confidence interval. So let's say we first, of course, have to do our meta-analysis, and the 95% confidence interval for reference versus placebo goes from 0.7 to 0.8. So step one, we usually convert this to risk reduction. Why? Because it's easier for us statisticians to think about it. And that's 0.3 or 30% and 20%. But we want to focus on this one. So 20% risk reduction is the minimum effect of the reference versus placebo. Then that's M1. It's the upper bound for event rates based on a 20% risk reduction. In relative terms, that becomes 1.25. So this is the minimum of the reference effect. Whoops. Sorry. To set then the margin, now we want to find M2. And let's say we want to preserve half of the effect. I'll just keep it simple at the half of that risk reduction. So now it becomes half of this 20%. So it's the 10% but it's 1 minus, and I change it back to the ratio multiplicative case, and it's 1.11. So now we'll be comparing the lower bound to 1.11. And this is just because they're looking at the multiplicative case. But if it's large values are bad, you're looking at the upper bound. If the large values are good, then you're looking at the lower bound. And it's just taken 50% or 75% of it to get the M2. Let's look at an example. This is actually a study that we were doing at McMaster University, and one of the investigators was nice enough to let me use the example from his study that was he was planning a non-inferiority trial. And so they were looking at the test treatment was this thing called factor 11 with aspirin, and the active control was this drug called anticoagulant drug called rivaroxaban plus aspirin. And so first of all, they did a meta-analysis, historical placebo-controlled trials of factor 11 versus an aspirin versus placebo, and they got these here. And if I thank him so much because he had it in a additive scale. And so they had a 20, so they had the meta-analysis had around a 30% or 29% reduction here. And these are the different studies. And this meta-analysis with random effects gave them this confidence interval. We're focusing on the upper bound of the confidence interval because they were looking at bad effects. And then that was M1. And then they wanted to preserve a certain amount of it. And it was determined that that's the amount that they wanted to preserve. And this is then the M2 that they got. So how did we get to that? Well, that was the result. So the meta-analysis ratio of events they expected was active control against placebo was 0.62. The 95% confidence interval actually differed. We didn't have only one. It just depended on different assumptions of the standard error. So the confidence interval could have been from 0.52 to 0.72 or 0.42 to 0.82. Reason is that they weren't really sure. They were basing it on not knowing the true standard error, but they guessed at it. They had two possible guesses. So they had three potential M1s, either 0.62 or then the upper bound 0.72 or 0.82. So the MIs were minus 0.38, minus 0.28, or minus 0.18. To preserve 50% of it, you take half of it, so minus 0.19%, minus 0.14, or minus 0.09, and then we convert it back to ratio of event rates. And so you had either 1.23, 116, or 110, and they went with the middle ground here of 1.16. Okay. So once you have that, what do you do? So this is how you determine the non-inferiority margins. Okay. But there are other issues. First of all, is once I've determined the non-inferiority margins, I need to know how does that impact my sample size. Okay. So I'm going to talk about that next a little bit. There's also how does it affect the interim analyses and the potential for early termination? Or does it have an impact on the conduct on analysis? What happens if it's open label, blinded non-inferiority? Do you do ITT? There's other issues in non-inferiority trials, and I'm going to now touch on some of these. Okay. Now, Dr. Jeyaseelan is going to be going into more detail about sample size, but I wanted to give you sort of the overall big picture of once you've determined your M2, which is your margin, that as in all clinical trials, is going to affect how you calculate sample size. So we all know that the sample size in a clinical trial is conceptually related to, if you want more power, you need larger sample size. If there's more variability of the effect or there's more noise in the system, you need a larger sample size. Usually the desired significance level is 5%, but if you wanted it smaller, you'd need a larger sample size. And then that margin is the difference here, right? And that M2 comes in the denominator squared. And M2 is usually small. And the smaller M2 is, then the larger the sample size is by a factor squared. And so the calculation of M2 is not a trivial calculation. It's something that's going to impact the cost of your trial. And so the smaller, you say, okay, I don't want it to be too much worse, so just a little bit worse I will tolerate. You're going to have a very large sample size. If you can tolerate more, then you'll have a lower sample size. But toleration is, again, usually established by the regulatory agencies and say, you know, you have to preserve so much of it. If you wanted to preserve 75%, then you would have much smaller, right? So that's why people go with 50%, for example. Now, for event-driven trials, if the event rate in the non-inferiority trials is lower than anticipated, power to demonstrate non-inferiority will be reduced, okay? So usually you monitor these trials as they're conducted. So there's usually an external data safety monitoring board that is monitoring. You may be monitoring the blinded event rates, but they'll be monitoring the unblinded event rates. And they may be, or you may be seeing the overall event rates and adjusting the sample size, which is a practice that's very commonly done also in superiority trials, if the funding agency lets you do that, of course. So what happens in this interim analysis? Well, you may be familiar with, in superiority trials, they usually consider early termination if they've demonstrated an equivocal superiority, or if participant safety is compromised, or if the trial is no longer considered going to give us any answers at the end, so it's futile to go on. You have very low power, for example. In non-inferiority trials, do we consider possible early termination? Yes and no. If you've shown inferiority, remember that you are looking for non-inferiority. But if inferiority has been shown in the interim analysis, then from ethical standpoints, to minimize patient exposure to some inferior treatment, the data monitoring committee may recommend stopping the study early for inferiority. Okay. If the participant safety is compromised, of course, or the trial is futile, are the same things that we do in the other trials. Now, if you are showing at the interim analysis that it's looking not inferior, usually they don't stop at that point because they want the confidence intervals to be tighter with more data to come in, okay? But if you actually, there's an exception. If you're actually not only not inferior, but you're superior, some groups will recommend going ahead and stopping because you've already shown superiority. There's a great article reviewing these topics from an ethical standpoint in the Annals of Oncology 2 years ago. Now, when we're doing the analysis of study population at the end of this trial, not at the interim, usually we, the standard in superiority trials is intention to treat, because that is the most conservative way to go. So whatever you were randomized to, no matter how you did, that's fine. In non-inferiority trials, what is considered the norm is not the intention to treat, it's the per protocol analysis. And you may have to actually do imputation of missing outcome data. But why is this so? Well, the intention to treat principle is considered conservative for superiority trials because, let's say, poor study quality, so you have a lot of protocol violations, or you have people not adhering, or you people dropping out, will tend to bias the results towards the null of no difference. So that's why intention to treat is more conservative. Now, in non-inferiority, as I said, per protocol is the norm because it's considered conservative. So poor quality issues could result in treatment groups appearing similar. So you're biasing the results towards the alternative hypothesis of non-inferiority. So poor quality makes you look not inferior. So non-adherence, misclassifications, attrition, loss to follow-ups can bias the results, again, towards no treatment difference and undermine the validity of the trial. So when we have the bias due to attrition, we end up doing imputations and missing data. So this is something to consider when you're doing the analysis at the end of the trial, that you have to do it per protocol and you may have to impute the data that is missing, okay? So what people do is that, to avoid missing data and to avoid having poor quality data, we always emphasize, especially in non-inferiority trials, that you must emphasize the study quality and continuously monitor the trial. Especially if it's open label, attention to quality is all the more important. This is not only stated in some articles, but it's in the guidelines to industry of the FDA. And the FDA expects them to monitor closely the data quality and the study quality in non-inferiority trials. So the final thing I want to talk about is presentation of the results, okay? And everybody, I'm sure, is very familiar with the CONSORT guidelines for how to present randomized controlled trials. And I'm sure you're probably also aware that CONSORT has guidelines for different types of randomized controlled trials. They also have guidelines for non-inferiority trials. So these were, I guess the latest ones were in 2012, and they're, the same one that I have from JAMA is available in the BMJ and Lancet and so forth. So they publish in a variety of places and also in different languages as well. But anyway, the CONSORT guidelines for non-inferiority ones say that the key issues that must be presented include the need to state the trial hypothesis. That's why I started by mentioning the trial hypothesis. And the non-inferiority margins. So given that little plot of the non-inferiority margins, the choice of this margin, how did you come out doing it? And then analysis using a confidence interval approach. So it is usually preferred that the reporting of non-inferiority trials is not with a p-value. It is with the confidence interval and the presentation and interpretation of the results using the confidence interval in relation to the margins. So that's why I was emphasizing from the beginning, you need to think about non-inferiority trials in terms of confidence intervals and their relationships to the margins, okay? And so when you're reporting this, you would say this was the margin, and this is what we got as our unadjusted result, did not go beyond that. And after we adjusted, it came close, but it did not go beyond that. And that's the way to present things. They also give some guidance on how to interpret things that, if you had gone over this, you would say it's inferior or it's inconclusive. I would call this inferior, but you had some that were positive. So it's interpretation is a big deal when you're reporting this, right? And if you happen to be superior, you're on this side and so forth. Here is that wanted to end up with this stent example, going back to it again and see how they did in reporting this non-inferiority trial. This is a study that was published in 2016. The guidelines of the CONSORT had been out since 2012. And so they reported here the upper limit of the one-sided 95% confidence interval was 2.27 percentage points. and this is on the additive scale, which is below the pre-specified 3 percentage point non-inferiority margin for the primary endpoint. Okay, so leading to the conclusion that stenting was non-inferior. So they do give the margins, and they present it here in the text. However, they didn't do the nice little graph that Concert has done. So even the New England Journal doesn't follow Concert guidelines, which they should. It's to some extent. Right? There's also, guidelines that can be done for interpreting the confidence intervals, and the difficult things. So here is one where I'm actually. This is an article that I wrote where I'm comparing the margins, and this capital delta 2 is now used gamma and -1 over gamma, minus gamma, and this is the delta, and this is the little delta. And so this is another way of sort of looking at all three hypotheses together and how one would go about interpreting confidence intervals in words based on whatever where you are and what was your hypothesis that you were looking at. So I wanted to end with giving some references, and this is the US FDA reference, and this is a great document. It's basically focuses on the appropriate use of non-inferiority study designs, and I'll be happy to share it if you're not able to download it. I can send it to the organizers of this workshop. So I'll stop there